Hi, I'm Elaine Rabin. I'm the program director of the Mount Sinai Elmhurst Residency in Emergency Medicine in New York City, and I'm going to kick off this group talk, Lessons from the Epicenter, Guiding Your Residency Through a Pandemic. As you know, the coronavirus surge was first really bad in the US in the New York metropolitan area, and the group of us represent programs for around the area. We were in touch and supporting each other during the pandemic, and our programs range from small to large, from community to academic, and from very new to very well established. We figured out pretty quickly that the lessons that we were learning were fairly universal across types of programs. So we put together this talk, so hoping they could benefit other people. At this point, of course, you have probably had your own experience in one way or another with leading a residency through a pandemic. So we're hoping that this talk serves as somewhat of a jumping off point for a larger discussion. We're also hoping that anyone who has the dubious distinction of being in the place where the next pandemic starts, or even where one of these new variants explodes, might also benefit from this talk, because our experience in New York differed from those that came later, in that the virus had spread so far before anyone realized what was going on that things in our area escalated particularly quickly. Just to give a bit of a timeline, January 30th, 2020, COVID still seemed like a pretty far away concept. We obviously knew about it. We knew that it was potentially coming, but nobody thought it was here yet. At that point, testing was still not very available. It had to be sent to the Department of Health or the CDC, and the guidelines were very strict. A few days before January 30th, the guidelines still said that only people coming from Wuhan and one or two other places should be tested. But this is the day that the pandemic started for me, because this is the first day that I had a patient at Elmhurst Hospital who had come complaining of flu symptoms. He had flu symptoms for a day or two, but 4 or 5 days earlier, he had flown from Shanghai, sitting next to someone with similar symptoms. So he was one of the first patients that met actual criteria for testing for COVID. This was a very big deal, not just the head of my department at Elmhurst, but the heads of the Elmhurst Hospital Center and of the entire city hospital system were suddenly on high alert. The Ebola room at Elmhurst got used for the first time. Everybody was breaking out the protocols and connecting, and a lot of group decision making. And then he tested positive for the flu. At that time, it seemed pretty far-fetched that someone could both have the flu and COVID. So he was discharged, and that was the end of that medically. The NYPD, however, had gotten wind of us working up a COVID patient, which caused a lot of rumors, a scare, and even a little bit of a dip in the stock market the next day, until the Department of Health put out a statement trying to squash the rumors, which is what this Daily News article came from. Imagine if every COVID test that was administered today moved the stock market. So after that, things were pretty quiet, at least as far as we knew, until March 3rd. In reality, nothing was quiet, and the virus was spreading in the community and spreading explosively during that time. But because we weren't testing anybody, and because it was still flu season, nobody was really aware of this. March 3rd, my colleague and APD Angela Chen was at work at Mount Sinai and had a patient who had come from Iran and thus met the strict testing criteria. And she became the first patient to test positive in New York. She had a mild case. She went home. Medically, there weren't a lot of repercussions. But again, this became a very big deal. The New York Times reported it. By the time Angela got home from her shift, her mother had driven from New Jersey, picked up her dog, her baby, and her nanny, and taken them all back to New Jersey to keep them safe, because she had already known about this case. So things moved pretty quickly from there. You all might recall, or even have been at Cord Academic Assembly, which was happening live just a few days later here in New York. And if you were here, you might recall that it was in person, but people were starting to get nervous, and day by day, more and more people were being told to come back home by their hospitals or risk quarantine. A day after it ended, I received a text from one of my colleagues at Elmhurst who said, guess what? There are 90 patients in the waiting room and they all have cough and fever. This wasn't just Elmhurst that was affected this way. This was starting to happen at hospitals across Queens, Brooklyn, the Bronx, in the boroughs where many essential workers lived and often lived close together in small apartments. So just 9 days after the first diagnosis, it was becoming clear that this problem was already much bigger than we thought it was. From there, things just changed very quickly. One day, emergency departments would mark off a small area to try and test COVID patients. The next day, it would have to be expanded. And usually by the end of the week, the entire ED was just considered a hot zone because there were so many patients. Protocols for testing, for quarantine, and everything else were changing daily, as were guesses as to what the best treatment was. It was really kind of a scary and very intense time for everybody here. Manhattan, as a borough, got hit a couple of weeks later, but same pattern. About 2 weeks after that was what has since turned into a very familiar pattern of people were entering the late stages of the disease in large numbers, and people were showing up really not just in large numbers, but very sick. This became the height of our surge in many ways in the emergency department. The city, luckily for us, had locked down by this time. So as quickly as our surge started, it actually peaked and started abating a bit. By May 1st in New York, we were well on our way back to a summer full of low virus levels. So our entire experience, which was very intense, was also shorter than I know some of you have had.
So now we're going to be moving on to lesson number 2, which was about communication during this process. My name is Chen He, and I'm the program director at Mount Sinai Morningside West.
And I'm Dorian Alexander, and I'm the program director at Brookdale Hospital, One Brooklyn Health System.
So perhaps the most important lesson that we learned during the COVID-19 response was the power of communication, or lack of it, and how these large-scale events are really as much communication emergencies and responses as they are clinical or resource emergencies and responses. And most of us realized early on how important and frequent communication should be to this process. Allowing residents to have the opportunity to discuss their concerns and frustrations was incredibly important, especially as the message that was coming from above or even from the CDC was often seemingly to be changing every day. Because despite our many past preparations, like the various MCI drills we've had at all of our sites, even we were not prepared for how often the message would change during the initial COVID response. So first, it's important to establish trust. Second, it's important to maintain transparency so people feel like the message you're conveying to them is genuine. Third, you have to really try to convey a consistent message. It was very hard for us to do this during COVID because the message was always changing. And so that's where the frequency of meeting came into play, so that our residents always felt like we were touching base with them. Fourth, it's important to listen to concerns and anxieties. And finally, it's important to get feedback about how this process was going for our residents so that we can make alterations as needed. So now we're going to just talk about some of the lessons that we learned, sometimes the hard way, when it came to this response that we all experienced. At the start, there are going to be many, many more questions than answers. For example, safety concerns was a huge topic of concern. And with us all being at teaching institutions with residencies, there were questions about who would perform procedures, specifically intubations, especially on these very high-risk sick patients, where first pass was the most important thing. PPE availability was a huge topic of conversation. Protocols for patients and staff and safety. Quarantine, were certain staff members going to be on furlough? All of these questions were raised before any concrete answers could be given. And it should really be at the forefront to provide a forum where these questions and concerns can be heard and addressed on a routine basis and with frequency.
So the hierarchy of communication has to run in both ways, bidirectional multi-level communication between administration, residency leadership, and residents must take place, and it must be in concert with the message from the GME and from the hospital administration as well. And these clear channels that are created must also allow for the residents to communicate information upwards, especially seeing that they're on the ground floor with the patients, seeing supply shortages, and they may be able to present operational suggestions to improve outcomes. The frequency and mode of communication matters. The message has the possibility to change when transitioning from person to person or from site to site. So it's very important that specific communication methods are used and they're consistent with programs, especially programs that have multiple different sites. The technological advances really have helped us with communication in this pandemic. So the use of multi-messaging platforms such as Slack, WhatsApp, Zoom, Microsoft Teams really helped in multiple forms of communication when social distancing was necessary. These platforms also provided a method by which residents could feel safety and reassurance that information was always being shared and someone was always available to hear concerns that they voiced. This is probably one of the most important things of communication that cannot be overstated. Apart from just the transition of information and operational knowledge, the support that is provided by consistent, reliable, clear, trustworthy communication is invaluable. The feeling of not being isolated, especially when in a dangerous environment, is imperative, and maybe even more imperative than operational changes. The providing of communication for support helps mitigate rumors, helps dispel fear, especially helps with mental exhaustion.
Hi everyone, my name is James Willis and I'm the Program Director for SUNY Downstate in Kings County in Brooklyn, New York. I'm sure I'm not alone in saying that resident illness is one of the scariest things we've had to deal with during this pandemic. We all know a large part of this job is feeling responsible and taking care of these young people we've taken in as apprentices. And a part of our role as being emergency physicians is that inherent risk of illness. But over the last year, that's felt more real and in our face. We ask our residents to put themselves in harm's way without really knowing what we were dealing with and what we could use to protect ourselves. In the next couple of minutes, I'll share with you what we experienced during the surge in New York City in terms of resident illness, including patterns and trends. This information is partly from our anecdotal experience and a publication from a survey of all programs from various specialties in New York City. As a group and from the data presented in New York City, we had many residents contract and fall ill from COVID-19 throughout the last year. Thankfully, very few were seriously ill, with only one ICU admission and none were fatal. I don't know the statistics nation and worldwide and from other specialties, but I know we were very lucky. I know a great many of us have lost colleagues, friends, family who have succumbed to this horrible illness. I would like to take a couple of seconds to remember them in silence. Thank you. What we all noticed independently was that when the surge was beginning, our residents fell ill early and in large numbers. A lot of this had to do with the residents' work hours, their role in being the primary provider in close contact for the majority of patients, and their consistent involvement in the care of critically ill patients. Anecdotally, we noticed that residents on rotations with significant and prolonged exposure to the critically ill and ventilated patients were more prominent given the amount of exposure. Symptoms were typical, with fever, anosmia, GI symptoms, and a significant portion of asymptomatic residents. The actual numbers are questionable, though, because as anyone who was following the news or working in New York City at the time knows, testing was not as robust as it is now. I know personally, and from studies published, there were significant amounts of untested and presumed positive patients and residents. Also, a significant aspect cited as a major factor in the timing and incidence of resident illness was the use, policies, and access to PPE. When the surge in New York City started, we were not being vigilant with PPE. We were not sure what PPE was necessary, and at times there was limited access. This contributed significantly to early resident illness. Due to the surge occurring in early days, quarantine policies were only being developed and constantly changing. In our experiences and what was published from other residencies, quarantine spanned from asymptomatic individuals with PPE use being exposed without proper PPE, symptoms, and even residents who weren't tested at all were put on quarantine. Contact tracing did not exist, and the infrastructure for infection control for the pandemic had not been developed. I've been a PD for only 17 months now, and as I get more and more experience, I'm coming to realize something that I'm sure all of you already know. A large part of being PD is catering to many different stakeholders and trying to do what's best for your residents, the hospital, patient care, while always keeping the responsibilities to the ACGME in mind. Resident illness and risk during this pandemic is no different. As for the PD perspective, I'm sure I'm not alone and that the primary thought is to protect our residents and do everything you can to keep them safe. A secondary aspect is protecting their education and learning experience. It fell on the PD often to manage clearance, questions of ability to return to work, what comorbidities or conditions should preclude a resident from being in patient-facing duties. Something that our group found was a best practice was to remove yourself from these decisions. We're too close to the people and to the decisions being made and need to defer to institutional policy from the GME, hospital administration, employee health services. I know from my experience, there were very difficult decisions of whether residents should be pulled from duty because of comorbidities or being pregnant. It becomes very difficult to be consistent and objective in those instances.
Hi, I'm Eric Steinberg, Program Director at St. Joseph's Health in Paterson, New Jersey, and I'm going to discuss Lesson 4, Fulfilling Staffing Needs Required Trade-offs and Guessing. At the beginning of the surge, residents across various specialties were redeployed based on need, mostly to the emergency department. Non-clinical areas, both inside and outside, were transformed into patient care areas within a matter of days. At larger institutions, GME offices coordinated redeployments, while at smaller institutions, committees were formed by residency and hospital leadership who took initiative to fulfill this purpose. With that being said, when local shutdowns were first implemented, emergency department staffing needs exploded as patient volume and acuity remained high for several weeks. And during this initial phase, EM residencies had no choice but to pull their residents from other locations. Larger programs and programs whose EDs were less resident dependent pulled residents only as needed, while smaller programs were compelled to withdraw residents from all non-emergency medicine, non-ICU rotations all at once to bring them all back to the ED. And during this phase, every single one of us struggled with finding some sort of balance between fulfilling staffing needs and providing the residents with a meaningful learning experience. We found ourselves faced with the following questions. The first was service versus education. Were the residents just here to don and doff and intubate and repeat? Will they ever see an acute abdomen, a trimal ankle fracture, or a sick child ever again? And then resident safety versus fulfilling their calling for the greater good. Should residents sacrifice their own safety for the population that they're to serve? Their attendings are doing it, right? Isn't this what we all signed up to do when we became emergency medicine physicians? Or should we be protecting the residents from all things COVID? They're the future of our specialty, and they're getting paid less than $20 an hour to do this, right? So why risk exposing them to something so deadly that we knew so little about? These are the questions that kept us up every night. Then several weeks in, suddenly, ED volumes decreased significantly. And we're talking 20, 30, 50% drop in some institutions. But despite this, intensive care unit volumes continued to dramatically increase as admissions kept rolling on in, and many ventilator dependent and critically ill patients on the unit were unable to be downgraded or discharged. So at this point, several EM residencies actually redeployed their residents out of the ED to these newly created ICUs throughout hospital properties. These were ambulatory surgery centers, endoscopy suites, and even pediatric wards. And as our critical care docs were getting spread thinner and thinner, these new units were often run by multidisciplinary teams composed of surgeons, anesthesiologists, and other disciplines who are not familiar with everyday medical ICU practice. So quite rapidly, it was realized that the emergency medicine resident skill set was invaluable in these settings. EM residents were able to effectively run resuscitations, they managed airways, and they performed life-saving procedures at the drop of a hat. Simply put, they got the job done. And during this, all programs withdrew residents from rotations that lost educational value. Elective surgeries were canceled, orthopedic injuries decreased significantly, and EMS ride-alongs were deemed to be more of a risk than a benefit. And of note, pediatric ED volumes decreased dramatically, upwards of 70% decrease in some institutions. Labor and delivery and NICU leadership even requested EM residents to be withdrawn from their rotations due to concerns about risk posed to their vulnerable patient populations. So while EM residents were in such high demand in some departments, other departments, for lack of a better term, simply wanted the EM residents to stay away. In smaller programs, most residents who were originally scheduled as vacation were asked to work clinically with the goal of shortening or reducing the number of shifts for their compatriots. Larger programs tried to protect vacations to preserve the physical and mental health of their remaining workforce. And these real-time changes to resident scheduling raised challenging questions regarding how much to borrow from the future without being able to predict the duration of the surge. Immediate needs needed to be balanced against the benefit of maintaining a cohort of healthy, rested, and happy residents. Additionally, several programs decided that non-ACGME required rotations such as orthopedics, administration, and some others would not be made up. A few programs took advantage of ACGME's emergency allowance to waive final year resident graduation requirements for procedures and rotations, and so they preferentially pulled final year residents back into the ED for patient care. And of note, amidst the increased work intensity and redeployments, solicitation and collection of feedback on resident performance was either de-emphasized or completely eliminated.
Hi, I'm Dr. Somil Parikh, and I am the Residency Director for Emergency Medicine at New York Presbyterian Queens in the borough of Queens in New York City. And today I'm going to talk about Lesson 5, which deals with new educational opportunities that emerged during the pandemic. So before we can talk about learning, we have to talk about fear. And I know a lot of my other colleagues already addressed this, so I'll keep this brief. But until I could master my own fear and overcome it, I wasn't going to be a good residency director. I wasn't going to be able to lead. I wasn't going to be able to teach. Nobody was going to put together lectures. And until I could stop myself from going home after every shift and watching hours and hours of nonstop CNN and just being a part of that whole hysteria and fear, I could not move forward. So that was my first lesson. And until I could do that, I could not move into the learning zone and teach everybody and then ultimately grow from it. So video conferencing, right? This became something overnight for most of us. We were not familiar with WebEx and Zoom and this and that. So this became something overnight that we had to master. And even though our residents tend to be more on the tech savvy side than us, nonetheless, some of them didn't have great Wi-Fi at home or had connectivity issues. There was also a lot of, initially we had to set some rules because this is kind of how it all started here in the middle. You can see it's just the core faculty is the only ones with their cameras on, and it was us talking to a bunch of empty boxes. So we had to quickly, move into some rules and regulations, kind of rules of engagement for conference, that you have to turn your camera on and you have to be upright and not, lying in bed, still sleeping during conference. Simulation obviously suffered. Simulation is a huge component of our education. We're in the sim lab every single week, right? It's how our residents learn. They want to learn by hands-on, kinesthetic, immersive experiences. And that was initially taken away from us when this all started because we didn't think we could get together safely and learn in the sim lab. So, and then we slowly we tried to do some virtual simulation, but trying to show people how to intubate a baby with a camera, on a screen, it's just not the same. It is just not the same. This is us in the trauma room. We had to sometimes use a bigger space as well in the actual trauma bay itself or in other patient care areas to do some learning because the space was bigger than in our smaller sim lab. Another thing that I might mention is the constant change of policies, right? So while you're trying to put together didactics and lectures and find out how you're going to get sim in and this and that, you have to constantly keep up to date with the plethora, the deluge of information that is being thrown at you. Sometimes the lectures that you would give, sometimes the lectures that you would prepare on Sunday, your PowerPoints would be outdated by Wednesday. You could use BiPAP on Sunday, and now you can't use BiPAP. But you also had to relay it to your residents, because without all of this, without all of these algorithms and what you can and cannot do, if you can't master it, how are you going to teach your residents to? PPE was a big concern in the very beginning. How do you use it? How do you use it appropriately? What's the difference between these masks with no valve, with and the mask with the valve? Why is an N95 so important? And then when we were intubating, I mean, I had never intubated with these anesthesia hoods, these respirators, and then I didn't know how to use it, how to put it on. This is our chairman here who is sending us memes on WhatsApp on how to put on a respirator, and not only put it on, but how do you still, with all that suffocating equipment, continue to provide good care? Another thing was systems-based practice. Many residents they're not necessarily interested in why things, administrative processes or this and that. They don't want to ever be hospital administrators. But during this time, their ears were definitely perked up. Why is the hospital making the decisions that they're making? Why are we building a tent outside? So a lot of this administrative processes, this this constant changing and evolution of the evolution of the landscape of the ED and the geography, residents really wanted to know why we were doing the things that we wanted to do. And then in addition, it was all the equipment, right? So whether it was just these viral filters that we were using for intubations, luckily we never had to actually use the ventilator splitters. I know people at other places were using 3D printers to make ventilator splitters. Thank God we never actually had to use that. But nonetheless, we had to learn about it, we had to know about it, we had to prepare for it in case it had to happen, in case we really had to ration out healthcare resources such as ventilators. And then of course there was oxygen, right? I mean, things like just a pulse ox and oxygen concentrators. I've never been, I've never had to really teach a patient how to use an oxygen tank or an oxygen concentrator. All the knobs and all the little details, I had to then teach that to the residents and teach that to my patients, and so that the residents could teach that to their patients. We also had to teach basic epidemiology. Why is it important to stay home? What is quarantine about? What is this thing that Dr. Fauci is talking about on the news about flattening the curve? And why is it important to stay away from high-risk individuals like the elderly and the patients with comorbidity? This was all stuff we had to, if you hated population medicine and epidemiology in med school, well, guess what? You had to really, really think about it very, very hard now and incorporate it into your daily practice. And then ultimately on rounds, there were many, many learning opportunities for pulmonary physiology, proning, ventilator mechanics, almost every day. It became something you had to master and you had to teach overnight. This became like the foundation of our conference. We weren't necessarily learning about snake bites and environmental emergency medicine. We were learning about pulmonary physiology, right? Because this is what COVID initially presented at. Everything was COVID, everything. It wasn't CHF anymore. It wasn't COPD. It was COVID. So we had to learn about multifocal pneumonia and ARDS and the ARDSNet trial, right? These were the x-rays that we were seeing and the CAT scans just riddled with ground glass opacities. It was all very, very scary. It started off as a pulmonary, we were seeing it more at the pulmonary manifestations, but ultimately it was the DKAs, all the crazy metabolic derangements that we were seeing, the thromboembolic phenomenon, the ischemic events also needed to be taught to the residents and done so in a very rapid manner.
My name is Dr. Arlene Chung, and I am the Residency Program Director at Maimonides Medical Center in Brooklyn, New York. And I'm going to be talking about Lesson 6, Stress, Anxiety, and Wellness Needed Close Management. We already knew that burnout was a problem even before going into the pandemic. This is a study that was published in the Annals of Emergency Medicine in late 2019 that highlighted just how bad the problem was. In the study, the authors surveyed all emergency medicine residents across the country using the Maslach burnout inventory. And what they found was that depending on the criteria used, the rates of burnout were as high as 76.1% for emergency medicine residents. And so we already knew that our residents were stressed and that they were at risk of burnout and, had all of these other factors going on that we were, so those of us in the wellness community that were already aware of and that we were already working on recognizing just how prevalent of a problem this was. And then 2020 hit, and then the pandemic hit, and it threw us all for a tailspin, both, those of us in the wellness community and really, our society as a whole. It's been a little while now, and I think in order to bring us back a bit and to really bring forward some of the emotions and some of the thoughts and some of the memories that many of us have had over the past year, I've actually chosen to highlight a few photos that were published in the Wall Street Journal by one of my residents, Duncan Grossman, who actually published a series of photos that he took during the pandemic. And my hope is that as I discuss some of perhaps what are our common fears and sort of our common lingering shared experience, that it'll help bring back actually some of those thoughts and feelings that many, many of us experienced. For our residents, this was a absolutely unanticipated, unique time, right? So we had massive amounts of patients coming into the emergency department that were super sick, and we didn't have a great way to treat them, right? And boarding increased, and all of the the known stressors for our residents and for our faculty became escalated and became really sort of critical and impacted our residents, in very obvious ways. But I think there were less obvious ways that our residents, and again, our residents and our faculty were impacted. And perhaps one of the most profound things that happened was the sense of our own mortality. So unlike many other illnesses where our residents, it's emergency medicine, so they're often confronted by death and dying, and they're not strangers to this. But I think what was really unique with this pandemic was that a lot of the patients coming in who were critically ill were young. And I think our residents were able to identify with them in a way that is not common, or at least not standard, I think, for many of their experiences, and certainly for many resident experiences previous to this pandemic. And I think that added another extra layer of stress. Not only that, not only concerns for their own mortality, but also concerns for their friends and their families. And this was such a mysterious illness, and the unknown was so great, and we didn't know how it was going to be transmitted, and we didn't know how much we were at risk, and all of these uncertainties and this sort of the blurring of the lines between patient and provider, I think, compounded a lot of the standard stresses that we would normally expect from high volumes and high acuity coming into the emergency department. Some of our residents, they responded differently. And for some of us in residency leadership, certainly we were confronted with some residents who really, they felt mobilized and they felt called to action, and they wanted to go in. I mean, no one was going on vacation anyway. So it's like, I'll give up my vacation. I'll give up my breaks. I'll give up, all these things, and I'll go into work. And for some of us, we had to, put the brakes on a little bit and remember that this is a marathon, although I think many of us didn't quite realize how much of a marathon at the time, but this is a marathon, not a sprint. And I do think that there was some element of the more I keep going, and as long as I keep going, I don't have to think about this, I don't have to process it. And that's certainly how some of the residents responded. Other residents, certainly took a different road, and they recognized the impact, the emotional and the mental toll that this was taking at the time. I think one of the most probably difficult things in speaking to my residents, for them, in addition to the mortality of all the patients they were seeing and the uncertainties of treatment, was simply the realities of living in a pandemic and, not being able to speak directly with patients, except through massive shields of PPE, and having to talk to family members on video chat, and not having visitors in the hospital, and all of those other, sort of not strictly, medical knowledge things about patient care, but all of those relational things were really impacted as well. And they saw this not just in the hospital, right? And people talk about how in natural disasters, humans come together and we support each other. And certainly that is true for, for things like tornadoes and hurricanes and earthquakes. But a pandemic is a different kind of natural disaster, and it actually brings us apart, which is really unique. And I think, particularly in residency, social support and social bonding can be so critical under normal circumstances for fostering resilience and for creating that safety net. But when those things were taken away from us back in the spring, and even now, as we're still sort of in the midst of this long pandemic, I think that really profoundly impacted our residents as well, right? So no more in-person conferences. Our residents never saw each other in person. Everything was switched to Zoom, and not just with each other, but also with their families. And our residents, they weren't able to rely on those same social supports that are oftentimes so critical and so important to maintaining healthy resilience in residency. So what did we do? I'm going to present sort of as a group collectively some best practices that we all employed. And while I can't promise that they all, worked 100%, there is no silver bullet to this type of thing. Our hope is that by presenting these strategies, that if something like this were to occur, or certainly if your, pandemic is not over, that this will be helpful to other residency programs across the country. Over and over again. So in all of our group discussions with, sort of the group of us, we all recognize the importance of bidirectional communication. This idea that transparency and access to leadership were of vital importance for our residents, feeling like they knew what was going on, that this helped mitigate fears of the unknown. And not only that they felt like they could go to, myself or my APDs or our chair and really suggest things and made them feel less out of control and made them feel like they had more agency in what was going on. Certainly providing mental health resources was very important. I know many institutions, offices of academic affairs, medical schools, and even third-party providers came flooding out, willing to provide mental health support. Both then and actually ongoing now for our residents and for our faculty. And certainly that is an essential component to managing a lot of the traumatic emotions and the feelings that were going on both then and now. Along those lines, the normalization of emotions was very important, and this is where role modeling comes to the forefront. We tried to the best of our ability, not just in our program, but certainly other programs, to find spaces, even though they were virtual, to really share our experiences and share our feelings, and to put those out there. Right. And in this era where, you couldn't get together with people, this was one way to feel less alone, to feel less isolated, to know that other people were feeling the same uncertainties and the fears that you were, right. And to normalize all that trauma and normalize all those feelings that everybody was experiencing. Focusing on the positive wins, this can seem somewhat trite, when you're in the midst of it, but really it does help to focus on the number of recovered patients and successful discharges, positive personal stories and highlights, really trying to focus on those things as much as possible and as realistically as possible to help prevent some of the ongoing, negative thought spiraling that certainly was prone to happen. And lastly, organized distribution of food and gifts. There were so many charitable donations from the community coming into our hospitals, making sure that there's some process so that they all get distributed sort of in a timely manner. And we recognize that, while getting free shoes or like a nice fleece is not a panacea, to all of the emotional trauma and all the mental trauma that might have happened, certainly it is a nice demonstration of thanks from the community, and certainly it is a morale booster. So, which is to say, our hope is that that by presenting some of these strategies, this can be helpful to your programs in the future. Should you ever, should we ever go through another pandemic, or certainly if you're still grappling with some of the after effects. And our hope is that at least some components of this your residents will find useful.
Next, I'll be discussing Lesson 7, Off-Service Residents Performed Critical Tasks. Many EDs receive residents redeployed from other services, but it quickly became clear that their skills only, partially translated to emergency medicine. But we did find our rotating residents to be particularly useful in two specific roles. And the first was performing oxygen rounds. The number of patients requiring oxygen quickly exceeded wall hookup availability. And so off-service residents rounded regularly on our COVID patients to evaluate for signs of distress, worsening hypoxia, or portable oxygen tanks running low. The second critical role our off-service residents played was communicating with family members. As every hospital enforced strict visitor policies, the availability of medically knowledgeable providers to update patients' family members was at a premium, especially as our volumes approached and surpassed critical capacity. Phones in the ED were ringing off the hook by family members who just wanted to know how their loved ones were doing. In many cases, these encounters included in-depth discussions related to patient prognosis, patients' wishes, and overall goals of care. Conversations were conducted via phone or video chat, and residents managed incoming calls. So overall, the off-service residents, their medical knowledge, their patience, and their compassion had a tremendous impact on patient care during the surge. And although these tasks may have seemed menial, awkward, or even atypical, they proved to be both life-enhancing and resource-saving.
Now I'll be talking about Lesson 8, Socioeconomics. The pandemic brought forth the light of healthcare disparities in low socioeconomic and minority communities. It really led to the unmasking of underlying healthcare disparities that previously existed. And it led us to realize that in these communities, these social determinants of health, to use a phrase that was coined elsewhere, became social determinants of death and led to worse outcomes in these communities. Minority and low socioeconomic populations, they had a risk for acute infection and disease due to long-standing structural factors that were in place before the pandemic even started. The lack of financial resources. They don't have the economics to be able to stay at home or to have reduced work hours because they were already working jobs that were under the standard rates. Multi-generational households that share a small confined space with family members that have increased comorbid conditions and younger family members who may have to go out and be the main breadwinner, then increasing the risk of exposure to the entire family. And then the understanding of the lack of trust that many of these communities have had in the healthcare system. All of these compounding factors, with multiple others, played a significant role. So all of those factors and more playing a role simultaneously in the peak of the pandemic led to these disproportionately higher rates of morbidity and mortality in minority communities. We see it in the Black and African American communities, the Hispanic and Latino communities, where the rates of death were significantly higher. And it was not necessarily due to the fact that the disease was different, but it is due to the fact that the underlying social determinants that were there from before led to these socioeconomic challenges. And as a physician in a clinical environment, it may be very easy to overlook some of those challenges. But an important lesson that we learned is that we can't do that anymore. The systemic resource challenges that the institutions themselves faced affected both inpatient and outpatient. Patients that would have come to the emergency department with relatively low acuity disease and may have been safe to convalesce at home, because of those social determinants, multifactorial again, they may not have been able to be discharged safely, whether that is access to telehealth resources, access to outpatient oxygen, access to pulse oximetry to be able to track and manage and monitor themselves safely at home may not have been available at the peak of the pandemic in those low socioeconomic resourced hospital systems. And as a result, the patients suffered as a result of a lack of those social support systems. So it's very important for us to understand that the ratio of admission, discharge, and ED boarding is proportional to the total number of hospital beds per population. In lower socioeconomic and minority communities, there are less hospital beds per capita. So that is going to lead us to a predictable pattern of overcrowding, increased boarding time, and ED dwell time in those communities. So hospitals in Brooklyn and Queens faced those predictable challenges far earlier in the pandemic than hospital systems that were more well-resourced areas and had more beds per capita. Some of those hospitals are probably still experiencing those challenges right now. So the lesson, there are a lot of factors at play and there are multiple roles. And the most important thing that we can do now to understand is that we cannot do it alone. Social workers, case managers, and our external affairs, they know our communities far better than we do. And we must work together with them to identify not only the clinical needs of our patients, but the social determinants of our community that affect their care. Each institution and the community that you provide has different social needs, and we must look to start addressing those needs as we move forward in the pandemic. In order to overcome these disparities and social determinants, we must stand together with our communities.
Hello, I'm Dr. Miriam Kulkarni. I am the program director at St. John's Riverside Hospital in Yonkers, New York, and I'm going to talk about how to prepare for the next pandemic. So this was definitely not the last pandemic of our careers for most of us. And the question is, what lessons have we learned from this pandemic that we can apply when the next pandemic comes? One important lesson is that your staffing needs are going to change. You should anticipate that your needs are going to change as patient volume increases in the ED and ICU, and also as residents from other specialties get pulled from their normal rotations. You should also anticipate illness in residents and make backup plans. As residency leaders, it's our job to help residents stay on top of the literature as the disease evolves. It's important to teach associated stuff such as vent management and pressor management, as well as management of the primary disease process. This is also an opportunity to teach residents how to evaluate emerging therapies and how to avoid misinformation. It's 13 months after COVID profoundly affected all of our programs, and all of us are tired. And yet, the pandemic is still profoundly affecting all of our programs. As the pandemic drags on, as any pandemic drags on, wellness monitoring becomes more and more important. Our second and third year residents have at this point spent more than 2 months in the ICU, as well as their time in the ED. This takes an enormous toll. Before you send a resident back to the ED or the ICU, where they're caring for these tremendously sick and dying patients, it's important to think about the dose that they've had already, the exposure to these patients that they've had already, or is it important for them to have a break? Maintaining program wellness is especially challenging because a lot of the things that we traditionally do to foster wellness in our program are unsafe. It's been especially hard on our interns because it's hard to feel included in the team. It's hard to feel solidarity with your co-residents. It's hard to build friendships when it's really difficult to see people outside of a work environment. It's really important to think outside of the box in terms of planning wellness when a pandemic is raging and gathering is unsafe. In preparation for the next pandemic, it's really important to define criteria for moving from in-person to virtual didactics and back again. When are in-person didactics safe to do? When is it safe to do sim labs or procedure labs or other learning that can't be done virtually? An upcoming challenge with this pandemic is that our incoming class of interns who matched last March had their clinical rotations profoundly affected by COVID. Many of them had clinical rotations that were pulled during their third year, their main clinical year. I had an applicant to our program tell me that his entire OB rotation was on YouTube without a clinical component at all. So it's important to anticipate that this incoming class's preparation for clinical work is going to be different than what we're used to. Another big part of preparing for the next pandemic is that the job outlook for residents is much worse than it's been in previous years. This is really frustrating for residents who've worked selflessly during the pandemic to then find that they're having difficulty finding a job when they graduate. It's important for programs to prepare to give increased support and advising to their graduating residents as they enter the job market. The world is a different place than it was last March, but we do know a lot more than we did last March. We've learned how to protect our residents from illness and despair, even as they work on the front lines. We've learned how to communicate effectively with residents, with stakeholders in the hospital, with our communities, despite enormous challenges. We've learned how to teach in an entirely new way. These lessons were extremely costly. Our patients suffered, our residents suffered, and our community suffered. But it's our belief and our hope that the sacrifices we made and the lessons that we learned from managing this pandemic will inform our management of the next one.
Yeah, well, I said it in the chat, but yeah, great presentation, guys. Really appreciated all of your experiences. They resonated and, kind of helped all of us digest the last crazy year that we've had. And I think that the main point that I think comes out in a number of your presentations and in my experience was just the amazing job that our residents did, faced with something that none of us have ever faced in our careers, and hasn't been seen in this country in a century. They rolled with the punches. They stepped up. I remember when we first started, we were kind of like, all right, residents need to stay out of these rooms. We're going to put these patients with, cough, fever, and body aches into isolation rooms, and only attendings will go and see them. Well, pretty soon, those patients were living in the hallways, and pretty soon, the residents were seeing all of them. And our rule about only attendings should face the risks of intubating these patients, pretty soon the residents were elbowing us out of the way and doing these intubations themselves. And they dealt with all this other crazy stuff like virtual conferences and, not seeing their friends and, no more red wine with Journal Club at a restaurant, and all this other, the adaptations. And, they rolled with the punches, they stepped up. And like I said in the chat, they'll be better docs and be better capable of handling the next pandemic as a result of the experience they had this year. And I think most of them appreciate that.
Absolutely, yeah. The residents are the true winners in all of this. I was very impressed at how resilient they were and how accommodating they were just on a daily basis. There was just all this level of uncertainty, and as leaders, it was hard not to show your own fear of everything and to like step up to the plate and really, comfort them and trying to get them through it. And they got through it. I'd like to think that we had a lot to do with that, but the truth is they were go-getters, and they were all strong, resilient people who definitely got through it. But going back to the wellness thing, it was definitely something to keep an eye on, to make sure there were always some wellness watchers that you were a little bit more worried about. I remember when we switched over to anesthesia only being able to intubate, there was, I would say 70% of our resident body was like, absolutely not. Like this is what we signed up for. And I don't want anesthesia coming down and, taking over the airway of this patient that I've been comforting and caring for the entire time. And then you had a smaller portion of residents who were like, that's totally fine. Let them come down and I'm totally fine. So you definitely had a variety of responses from the residents, but overall, they were the true winners in all of it.